we wait for a few more minutes just in case?
We are live, Anuj.
Yeah. Should we wait for a few more minutes?
No, the participant list is going up.
It's going on, right?
It's populating right now.
Because do you guys see my screen big enough? Just one second. Is it visible as a full screen or my slides, Aditi? Is it visible for you screen?
Yes.
A full screen? Yes. Okay. Okay, so welcome everyone to the webinar series, Battling Emerging and Re-emerging Epidemics and Mitigating Strategy. Today is our first panel discussion on COVID-19 mathematical models. Good morning to everyone here in US, and people are also joining remotely from different parts of the world, including India and Africa and South America also. So, well, during this unprecedented times of COVID-19 outbreak, some of us have gathered from different institutions to quickly put together this webinar series and to address some of the novel aspects of mathematical models, as well as to see what challenges we are facing for modeling the current problem that is coming out of the COVID-19 pandemic. So just to briefly describe about this joint initiative, this is a joint initiative from researchers at University of Wisconsin-Whitewater, Intercollegiate Biomathematics Alliance, Illinois State University, Arizona State University, George Mason University, and Precision Hire. And we are here to discuss the complex mathematical modeling challenges, theoretical and fundamental principles that are going in these models. Also, what are the aspects of the prediction that we can use or not use from these complex mathematical models. And the overall goal is to, if we can understand the transmission dynamics of the current COVID pandemic. So before I go into details about the panelists and the process that we will follow today, let me please introduce you formally to the organizing committee members. The first is Dr. Aditi Ghosh. She's a tenured track assistant professor at the University of Wisconsin-Whitewater, an alumni of the mathematics department of Texas A&M University College Station. She has been involved with various national and regional outreach activities, including organizing workshop for the Association of Women in Mathematics. She has also been successfully engaged in recruiting and preparing undergraduate minority students, especially for the first year colleges in the Midwest region. Her research interest is also in the mathematical biology, and she has been working on preparing undergraduate students for the national modeling competitions. She's served as a mentor for National Alliance for Doctoral Studies in Mathematical Sciences and the Cross-Institutional Undergraduate Research Experience Program. Second member of the organizing committee is Dr. O.J. Akman. He's a professor of mathematics and the director of Center for Collaborative Studies in Mathematical Biology at Illinois State University. He's executive director of Intercollegiate Biomathematics Alliance, a consortium of universities collaborating to advance research and education of mathematical biology. Dr. Akman is currently serving as an editor-in-chief of two research journals, Letters in Biomathematics and Spora, which is only journal in the world with an exclusive focus on student-driven research in mathematical biology. He's founding director of BEER Conference, Biomathematics, Ecology, Education and Research Conference, and also nationally recognized soccer referee. Today, unfortunately, due to family emergency, he's unable to join us at the last minute, but probably he will be joining us late. The next member of our committee. Oh, OJ, greetings.
I just came in. Thank you so much.
Sure, sure. So next member is Dr. Padmanabhan Shashir. He's a tenured professor of mathematical sciences at George Mason University and serves as a director of STEM Accelerator program in the College of Science, as well as director of COMPLETE, which stands for Center for Outreach in Mathematics, Professional Learning and Educational Technology at George Mason University in Fairfax, Virginia. His research interests are in broad areas of computational mathematics, computational data, biomechanics, design and system thinking, and STEM education. He has been an NSF program officer for a number of years as well. The next member is Ms. Rebecca Berlin. She's a program coordinator for the Presidential Award-winning and nationally recognized NSF and NSA supported Mathematical and Theoretical Biology Institute research experience for undergraduate summer research program. She has been guiding students through MTVI program in professional development activities, as well as coordinating projects in higher education. She has worked in geographical information systems with focus on ecological and epidemiological applications. And her research includes spatial modeling of natural habitats, sustainability and connectivity. So these were the rest of the members. Well, before we go into hearing from our eminent panelists, their views on some of the questions that we will put in front of them, I wanted to give some outline of why we are doing this panel discussion on COVID-19 at this point of time. And we were debating on these things for quite some time, and now we are kind of in a way to share our views and our points. So as of yesterday, the United States is struggling with around 4 million total cases, around 143,000 deaths due to COVID, which is unprecedented. And there are worldwide around 15 million total cases and around 600,000 deaths. So this is, nevertheless, the disease has been damaging effect in at least 6 continents. So it is affecting every parts of the world, and it has literally changed our normal life to a standstill in some sense. In spite of vast literature on mathematical modeling of infectious disease, the use of models in predicting COVID patterns has been very limited. And this is why we are gathered here to see existing models have been valuable in the literature for other infectious disease, but they were not designed to support types of critical decisions that are related to changing COVID informations that we are learning every day, for example. So, well, one of the good example is initially in the outbreak, the models from Imperial College and Institute of Health Metrics and Evaluations, which came to the limelight in the news media, have been way off in predicting disease burden accurately. So this is one of the reasons we thought of why is that happening, and if we can understand better from an expert in this area. Another reason is, for example, public health departments around the globe need to allocate COVID-19 related resources. Every country has a limited supplies of many related to healthcare staff or even the hospital beds, for example. So how do we optimize and how do we allocate? And mathematical models can help in understanding those things in a better way. Although COVID has resulted in numerous problems to individual and society as a whole, But I must say one very important fact that we are seeing in COVID pandemic, which is a good news from the COVID modeling perspective, which is it is becoming more popular, these terminologies in news medias and news articles, which was considered as a complex issues. So what mathematicians are now aiming to do is to make these things understand in different articles so that common people can understand it and can get an idea about what models can do and what models cannot do. But natural questions to ask when these things are coming into picture, the natural questions that come to our mind are, why have models failed earlier in predicting trends and patterns? Are there scenarios where the models are helping? Um, there are vast number of modeling results. Which one to take? Which one to consider for our designing policies? Are there protocols in accepting those results? What are the best practices when it comes to mathematical models, development, design, and implications from the modeling world? So these are some of the things that brought us together and have invited these experts in the field to draw their insight into it. The focus of today's webinar series will be to discuss related to why mathematical models have been able to capture COVID trends only in some selected scenarios, and why they have been limited scope in managing this spread of disease through various non-pharmaceutical interventions, as well as how models can adapt to battling the efficacy of interventions on both local and global scales. So to this end, let me introduce to all of you our eminent panelists. Today's panelists include Professor Mac Hyman. He's a professor. He's Elwin and John G. Phillips Distinguished Chair in Mathematics at Tulane University. Second is Professor Ellen Lloyd. He's a Drexel Professor of Mathematical Biology and Director of Biomathematics Graduate Programs at North Carolina State University. And the third panelist is Professor Gerardo Chovel. He's a professor and chair of Department of Population Health Studies at the Georgia State University School of Public Health. Before we start, I would like to respectfully convey some ground rules. So I think I was supposed to change my slide. So let's see. So these are some of the ground rules that we have. Just to mute your microphone, that is the most important one. And I hope you will enjoy today's panel discussion. And please use chat message to provide your questions and for the panelists. So before we start, this is the rest of today's activities will include 5 minutes presentation by each of the three eminent panelists, followed by of panel discussion. We will ask few questions to our panelists, as well as we will request all our audience to provide question in the chat box, and we will use some of those questions to and put in front of our panelists to draw their insight into it. And then we will end the panel discussion with some closing remarks by each of the panelists. So again, I want to say that 5 minutes presentation by three panelists, around 30 minutes panel discussions, and followed by closing remarks. With that, without any further delay, let me please introduce you to our first speaker, Professor Mac Hyman. As I said, he is an Evelyn and John G. Phillips Distinguished Chair in Mathematics Department at Tulane University. He is a past president of Society of Industrial and Applied Mathematics, a fellow of AAAS, a former group leader of the Los Alamos National Laboratory Mathematical Modeling and Analysis Group. His research centers on quantifying uncertainty and creating disease transmission models to help guide the medical and scientific community better understand and mitigate the impact of emerging infection. Well, at a personal note, he has been a long-term strong supporter of an MTBI program, which I have co-directed for a number of years. And he has been instrumental in organizing the MTBI also at the Los Alamos National Lab for a number of years, which has not only provided students to work on a cutting edge research project, but also have provided a real life experience at this world-renowned national lab. So with that, let me also give you the topic of his talk today. His talk title of the talk is How Modeling the Spread of Epidemics Has Changed Over the Past 40 Years and the Current Efforts for Forecasting the Current Coronavirus Epidemic. Please help me in welcoming Professor Hemant.
Thank you, Anush and Aditi. It's very timely for this panel discussion. There's never been a time when our mathematical community has been more prominent in the public eye than we are right now. And first, I want to say we can really be proud for how the community's responded to the pandemic. The huge number of models to help public health workers and decision makers understand the spread of the epidemic and the mitigation. Although a huge number of models is a blessing, it's also a curse to figure out which ones to believe and which ones not to. This isn't the first time that mathematicians have really been called to help in responding to a pandemic. I mean, mathematical modelers and statisticians have been part of our public health system for decades. But traditionally, up until about 40 years ago, the main role was to analyze statistical data and maybe use very simple models to understand herd immunity and the levels of vaccination. And there's a real tipping point. Everything changed dramatically in the late 1980s. And in 1988, the president of the US asked the Office of Science and Technology Policy, OSTP, to find out how applied mathematicians and modelers could better help fight emerging infections. And so at that time, 100 applied mathematicians and modelers, epidemiologists, public health workers went to Washington for a week to create a national effort for modeling, at that time, AIDS epidemiology. But it was really the beginning of a national effort for models to help fight infectious diseases. And I say we were there for a week, but it were 24-hour days. And the report that came out is still worth tracking down. It had some of this, exactly the same questions that we're dealing with today. We soon realized that simple models weren't sufficient to understand how AIDS was spreading, and there was a need for more complex models. But we lacked the sufficient data to determine the model parameters. Medical and public health workers were not releasing their data at that time, sometimes for years. And that was a major recommendation of the report, is to find platforms so that researchers could quickly release their data so that it could be incorporated in the models to improve the forecast. At that time, the CDC had almost no manpower to organize and distribute the available data and maintain confidentiality. So the HIV/AIDS modelers were really modeling in the dark. But what it did do is it galvanized our community from probably less than a dozen or so people, at least in the US, modeling epidemics, to tens or maybe dozens of people to create improved models. So this is when I got involved. Carlos Castillo Chavez was involved in. Herb Heathcote was one of the major leaders in the field. And the models raised up from simple ODE models to start including things like distribution of risk of infection, how many contacts people have. The model started accounting for time since infections. They became ODEs, became integral partial differential equations. And finally, agent-based network models came into their own in the late 90s, early 2000s that captured social interactions of everyday life. And these models really galvanized the people, NIH. And NIH responded by creating a new program called Models for Infectious Disease Agent Study, or MIDAS, in 2003. And they realized these large scale, to do accurate predictions would take many, many years, many, many researchers in many, many universities. And so MIDAS funded teams of researchers around the country and around the world, in fact, including Imperial College, to build large-scale models to help public health workers understand and control the epidemics. The first big test was the H1N1 novel influenza virus in 2009, where these large codes and these teams of people gave guidance for how the vaccine should be rolled out, since at that time, there wasn't a vaccine ready when the epidemic started. And the models came up with the guidance that school children and public health workers should be vaccinated first, and then the vaccinations should follow the path. Whoever has the most contacts should be first in line. In 2014, the Midas group responded for the Western Africa Ebola epidemic. In 2015, the chikungunya epidemic, and now the coronavirus epidemic. In the early days of Midas, only the people funded by NIH and the Midas program were allowed to attend these meetings. It's now an open organization, and I encourage anyone in the audience out there to go to midasnetwork.us, M-I-D-A-S network.us, and check out their websites. It's an organization that's open to anyone modeling epidemics. They sponsor workshops, online lectures. There are GitHub repositories for data, estimates of parameters, and you're welcome to join the organization, but join the working groups for coronavirus. Now, many of the Midas team members are now also part of a new effort at the Centers for Disease Control, the CDC, to combine their models to create what's called an ensemble model, such as when we model hurricanes now. There are many, many hurricane models, maybe a dozen, and we don't trust any one model in all situations. So all modelers will predict their forecast. In this case, Hurricane Hana is heading for the US. And we get tracks of about a dozen hurricanes. And from these, we calculate what the median expected path is. Our modelers are now doing that for the coronavirus. And if you go to the CDC website for coronavirus, you'll find weekly predictions of over about 24 models for the future of the epidemic. Now, one week, one model may be better, and the other week, another. Now, we all have their favorite models. Gerardo, right now, your model is my favorite. Sometimes it's done better, sometimes not. But by using this ensemble model, we can combine, kind of get a crowd wisdom of many, many people. We're fortunate to have so many dedicated and smart people working now, and that the CDC has put this website together. And again, it also is open. And so I encourage everyone to kind of join the community. Because one of the biggest problems in modeling is that if you've worked for this model for weeks, decades, as I've done on some, sometimes you get too much confidence in your own model. And my personal feeling, the main obstacle to progress in modeling epidemics is not our ignorance of the mathematical model, but it's having too much faith in the models that we do have. And that kind of gives us an illusion of knowledge that isn't there. And by collaborating and giving feedback, we reduce that risk. So Anush, that was a quick flyby for what's happened in the last 40 years to get us where we are.
Well, thank you so much, Professor Hyman. I mean, this is amazing to know that how it has been evolved over a period of time, mathematical models, and also talking about how it was related to the AIDS and HIV epidemics.
So I really do encourage people, this is available online. And it was written 40 years ago, but it's just as relevant today as it was then. Sure. Actually not 40, 32 years ago. We're facing exactly the same questions now.
Well, we could also put the picture of this this on the website so that everyone can access it if later on they want to come to it.
Okay.
So thank you once again, Professor Mac Hyman. This is fantastic to know this historical perspective on mathematical models and its evolution, and what the different agencies in the nation have been doing, like MIDEX, for example, that you were mentioning, and also some of the tips about having too much confidence, especially under the circumstances when the information and the knowledge about this current pandemic is kind of continuously changing as we are going over time. So thank you once again. So moving forward, next I would like to introduce Professor Alan Lloyd, who needs no introduction as he is very well known in the mathematical biology community. Professor Alan Lloyd, as I said before, is a Drexel Professor of Mathematical Biology, Director Biomathematics Graduate Program at North Carolina State University, and he held postdoc position in the Department of Zoology at the University of Oxford. And in the program, I think my internet is being unstable, my apologies. And in the program in theoretical biology at the Institute of Advanced Study at Princeton University. His interest lies in mathematical biology, particularly in the ecology and evolution of infectious disease. His work on mosquito-borne infections includes modeling and the use of genetically modified mosquitoes to control dengue virus. He's also interested in spatial processes in epidemiology, ecology, and evolution, parameter estimation, and uncertainty quantification for models of biological systems. Well, he has worked with a very well-known pioneer in the mathematical biology field, Robert May. But as a personal note, he has been a mentor at MTBI program and has visited regularly guiding students in the MTBI program. I deeply enjoy our long conversation at various conferences, including the recent joint mathematical meeting in 2020 in January in Denver. So since then we have been in the lockdown, but today's topic of the talk is modeling contact tracing. So Professor Alan Lloyd.
Okay, so I'm going to try, I have some slides, so I'm going to try and share my screen. Host disabled attendee screen sharing. Someone who's a host is going to have to allow me to share my screen.
Rebecca, can you help him?
It should be set there, Alan.
There we go. Thank you. Okay, so hopefully you can see my screen now. Yep, can you see my screen?
Yes.
Good, good. So I'm going to talk a bit about a project I've been involved with looking at contact tracing, specifically for COVID-19. So this project is headed up by Kevin Esvelt, who's at MIT, but most of the work has been done by Will Bradshaw, who's a postdoc in the UK. So this is a picture showing the so contact tracing is a very standard approach to try to control an emerging infection. And the basic idea in the standard approach is from a known case, you try to find and isolate contacts who that known case might have had and who they might have infected. So in this picture here, I'm not sure if you can see my mouse. Can you see my pointer or not? Yes, very good. So this guy here is the known case that was identified. They in turn had been infected by someone else, but then we see their various contacts. And what are the problems with contact tracing? Well, you don't always find all of the contacts. You go to the person, you ask them who have you interacted with over a certain period of time. Maybe you don't find all the contacts. But maybe you don't find the contacts quickly enough, because maybe you don't find the contact until after they themselves have become infected and have infected other people. And another question is whether you need to trace your case, your index person, before you start the contact tracing. So do you just go on symptoms and say, okay, we think this person's a case, or do you have to test them and then wait a while and then say, yes, this is a case, we go look at their contacts. And a question that's come up and has been proposed as a panacea during the COVID outbreak has been the use of digital approaches. So for instance, using cell phones. So cell phones can tell using Bluetooth when they're within certain distance of each other. And so cell phones, in theory, can help you identify and keep track of contacts of people. Although there, of course, there are lots of privacy and big brother type issues that come up when you start talking about using cell phones to figure out where people are and who they've met. There are specific issues with contact tracing for COVID because people are infectious before they show symptoms. So we have this so-called pre-symptomatic transmission. And in lots of cases, lots of instances, people can be infected, can infect other people, but be asymptomatic, so not show any symptoms. And so both of these are highly problematic for the standard way of doing contact tracing. So our project has been looking at this idea of doing bidirectional contact tracing. Not only try to find who a given person has infected, but try to find who infected them. And that then will reveal more people in the transmission tree. And you can do this by, the current guidelines say you ask people to list their contacts up to 2 days before symptoms appeared. But if you can figure out their contact starting from 7 days beforehand, you should be able to figure out who infected them. Now, of course, if you're asking over a longer period of time, that will give you a much longer list of contacts. There's a lot more work for contact tracing to do. But maybe if you're doing digital approaches, that can help mitigate that burden. So we employed, so contact tracing, as I said, has been long been used and proposed as a way of controlling newly emerging infections. And so there's been a fair bit of work looking at how well contact tracing works. And so very early during the COVID pandemic, this paper by Helliwell et al. From the London School of Hygiene and Tropical Medicine group appeared. And this paper has been very highly cited. And it was looking at the standard approach for doing this forward contact tracing for an emerging infection. And they were relatively positive about the chances that it would work, provided that you started off early enough during an outbreak. Although I should say they had some rather optimistic assumptions about various disease parameters and timescales. So one thing to say, you know, contact tracing, as I said, depends a lot on timing. So you have to, in models for contact tracing, you have to worry a lot about how long it takes between someone getting infected and becoming infectious, between getting infected and showing symptoms, and then delays in terms of things like testing and how long it takes to isolate people and so on, and how long it takes to trace people. So we took these guys' model and extended it a bit, and using some more realistic parameter values, we found a rather sad story that the standard way of doing contact tracing was rather unlikely to be able to control an outbreak of COVID-19. So even if you had a relatively high probability of being able to trace a given contact, the proportion of outbreaks that you could control was rather low, and the reduction that you could get in the effective reproduction number, you could get it down from 2.5 to various levels, but you weren't getting too close to 1. But we found that if you change the way that you did contact tracing to include this bidirectional tracing, you could have some degree of additional success here. So we could double the fraction of outbreaks controlled, and we could bring the effective reproduction number much closer to 1 than if we just did the standard forward contact tracing. Difficult to explain how this graph works, but I'll just put it up there anyway. One thing we found is that digital contact tracing is rather sensitive to uptake. So not everyone has a smartphone. So you need a smartphone to do this digital contact tracing. And also people need to be willing to share information on their contacts. And so not everyone's going to do that. And it turns out this digital contact tracing is really sensitive to that level of uptake in the population. If you think about it, you want to figure out if one person has met another person. So you need both members of the contact to be in the scheme in order for it to be able to identify that contact. So rather than the probability of finding a contact depending linearly on the uptake, it depends quadratically on the uptake. And so it's much more sensitive to low uptakes. So one reason we did this is that at some point, I guess Apple has pushed an update to include contact tracing in the OS itself, but you have to decide to turn that on. And so there's a question there as to whether these updates should be mandatory or optional. So there would be a big benefit if the update was mandatory, but there are big privacy questions that come along with that. And I should say also in different countries, there is different tolerance for a centralized system where the government basically, or the health system runs it, versus basically a private thing where the information is retained by individuals and only shared when they want to. And then what we found is that if we hybridize the bidirectional contact tracing with a digital approach, it really does improve performance. So you get a much higher fraction of outbreaks controlled, and you bring your effective reproduction number much closer to 1, although you still need quite a high uptake in order to actually bring it down to 1. But I'll say a little bit more about that in a second. So the pre-symptomatic and asymptomatic transmission makes contact tracing really challenging for COVID-19. Unlike some of the early statements that we saw back in the late winter, early spring, digital approaches are not a silver bullet unless there's near universal adoption. Bidirectional approaches really help increase the effectiveness of contact tracing. And it turns out, maybe sort of accidentally, the approaches that are used in Japan and Singapore when they do cluster analysis actually include a bidirectional component. That might explain why they've been successful. But one thing to remember is we have multiple different approaches to control at our fingertips. So we don't necessarily need one control to work by itself. So if we combine this bidirectional contact tracing with even a mildly effective other control measure, such as wearing masks, that really would help bring effective reproduction numbers below 1. And here's the reference to the preprint. The paper's currently under review at some journal or other. And so I will, if I can figure out, stop sharing. There we go.
Thank you, Professor Lloyd. This is amazing. I think this is one of the important aspects about contact tracing, especially in the COVID, because of the fact that many of the, as you said rightly, that there are lots of cases which are asymptomatic and not showing symptoms. So contact tracing start to become, and also it's important point that you kind of discussed in some ways is about how alternative data sources can be used also to study these epidemiological aspects like digital tracing, for example. So thank you for this fantastic talk, Dr. Professor Lloyd. Moving on further, I would like to introduce and invite Professor Gerardo Chowell, who has been my collaborator and colleague for a long time. He's a mathematical epidemiologist with over 15 years of experience in studying infectious disease dynamics using mathematical, statistical, and computational techniques. He's a professor and chair of Department of Population Health Studies at Georgia State University School of Public Health. Also an adjunct faculty at Arizona State University. He's a senior research fellow in the Division of International Epidemiology and Population Study at Fogarty International Center, National Institute of Health. He has considerable experience in development and calibration of mathematical and computational models to investigate emerging and re-emerging infectious disease outbreaks with the goal of estimating key transmission parameters, generating disease forecasts, and assessing the effects of control interventions. He's recently participated in coordinating of the Ebola Forecasting Challenge, which brought together teams representing 16 institutions and government agencies, an effort that played an important role in coordinating the modeling community. He's currently a member of editorial boards of several key journals, including BMC Medicine, BMC Infectious Disease, PLOS One, Journal of Infectious Disease Dynamics, and Scientific Reports. I've known him personally since my doctorate studies. In fact, my initial publications have been with him. So I've been lucky to work with him. His today's talk's topic is a real-time forecast of the pandemic at different spatial and temporal scales. Professor Gerardo Chowell.
Thank you, Anush. Can you hear me?
Yes, yes.
Okay, I just have a few slides, and I think the main, thank you very much, by the way, for the introduction. I'm very happy to be here. Let me share my screen. I just have a couple of slides. Anush?
Sure, please do, please do.
Can I do that now? Okay.
Yeah.
Right. So, okay. Can you see it? Can you?
Yes, yes, we can see it.
Okay. So I thought I would start with this slide that it just came up this morning from the New York Times, who, you know, they have a bunch of great scientists there working on the pandemic as well, which highlights, you know, the fact that this virus is really behaving, you know, in rather different ways from what we were expecting at the beginning. If we were thinking that this was going to be behaving like an influenza, you know, like a pandemic influenza virus, where we can see that the curve, the national curve of the US, right, it starts to grow rather sub-exponentially, I would argue. And then obviously this hides a lot of heterogeneity in the dynamics across different states and different spatial scales. It reaches a peak and then a decline as a result of the shelter-in-place orders, lockdowns, et cetera, which was, by the way, has been a patchwork in this country. And then it starts to decline, right? Then states, different spatial scales, even counties influence the resurgence later on as a result of the relaxation of the social distancing intervention measures. And now we are seeing a significant resurgence of the disease. It appears that we are reaching a plateau, leveling off. And so this highlights the fact that when we look at these epidemic curves at different spatial scales, they all hide substantial heterogeneity, right? If we look at the national curve, for a country, you know, as large as the United States, it's hiding lots of heterogeneity in the dynamics that is occurring in different places at the state level, at the county level, at the zip code level. And we need to take that into account. If I were showing you the curve for pandemic influenza in the United States or in Mexico back in 2009, you will be seeing relatively well-defined waves of the virus, right? The first spring wave during April, May, with a very well-defined peak. So the disease grows during a finite set of doubling times, peaks, and then declines. And then we keep a relatively low level during the summer months until school-age children go back to school and we observe a resurgence. But this is obviously behaving quite differently. And I think this is a great opportunity to improve our models, models that account for lots of spatial heterogeneity. I think there's a need to improve our models, our thinking on how we integrate the diversity of epidemic patterns that are unfolding at different spatial scales. And in this slide, I try to convey that message, right? The fact that you may have a pathogen spreading from a particular source, let's say the Wuhan, the market in Wuhan, for instance, if that was the source. And when we look at the curve, we are really counting the number of cases as a function of time, but we are not able to see the fact that there were, you know, cases stemming potentially from contaminated sources in the market versus cases arising from human to human transmission, or cases stemming directly from healthcare settings. So we tend to observe cycles, right, of different frequencies and durations. And these cycles repeat themselves at different finer spatial resolutions. And when we try to fit our classical models to the data, they often fail, particularly, you know, when we are dealing with metapopulation, even metapopulation models that are well mixed. They tend to fail because there is still a need to improve the way we integrate this variability. And one of the sources of variability is super spreading events, right? That are often difficult to predict We don't know when they will occur. They occur highly sporadically. The size of them also varies quite a bit. And so when we try to fit the models, right, we are having a hard time in the absence of, you know, detailed information. Ideally, you would want to have the transmission chain of the virus, right? Here in the top right side, you can see the transmission chain of the SARS-CoV-1, the SARS-CoV outbreak in Singapore back in 2003, where researchers from Singapore were able to trace pretty much who infected whom, right? And this was, you know, confined to healthcare settings. So it was actually feasible to do this level of contact tracing and reconstruct the transmission chain. When we look at the epidemic curve, you can see that there are well-defined waves or sub-epidemics, the way we call them, in the work that we have been conducting, actually in collaboration with Matt Hyman. And understanding how these sub-epidemics arise, how quickly they occur, their synchronicity, right? And how, when we aggregate them together, shape the overall dynamics at different spatial scales. I think that's a very fruitful area of future research. And in that line, I'll just, you know, very briefly talk about when we look at these dynamics without putting too many mechanisms into it. When we look at the dynamics as a way, as a function of sub-epidemics that arise under very simple mechanisms, we are able to improve our characterization of these waves, right? We need models that can actually recover stable incidence patterns, right? This is the first example right here. We need models that are able to recover leveling off of the disease, right? Not only one single peak, but sometimes we may have broad peaks because the aggregation of these sub-epidemics at finer scales can give rise of those patterns. And potentially also oscillations, right? Oscillations that may have different degrees of overlap. So we can have weekly overlapping subepidemics, right? When they are weekly overlapping, they will tend to generate oscillations. When they are strongly overlapped, they will tend to generate one single broad wave of the disease. And you know, we have been using this type of framework, and we are working on extending it to more mechanistic approaches now that we have more and more information about this novel virus. And we have been using it since 2009 for forecasting Ebola in DRC, and more recently forecasting the epidemic in different hotspots, particularly those in Europe, in New York, in the United States. Here's one example for Germany where you can see how the overlap, right? Overlapping these sub-epidemics with a particular structure is not random. It gives you a much better fit to the data. And also it helps you forecast in the short term. We are doing 20-day ahead forecasts, and the models have been doing a very decent job, I would say. And also highlighted, this is a great opportunity to record the performance of all our models, right? To see how well they are performing and to find ways to improve them. So we need to keep record. We need to keep a journal of performance, and we need to use consistent metrics to assess how well the models fit and how well the models forecast. And it's only in that, you know, in that direction I think we can actually make progress. Here's a few other examples. Let me share also quickly the most recent forecast that we are doing, and we are publishing them in real time. These are weekly updated weekly. So we use the data on Sunday, the data as published by the New York Times at the state level and the national level for the US. And as you can see, we have been, since July 4th, we have been publishing the national and state level forecast for many of the states in the United States, where you can see that we are not only recording the forecasting performance, but we are also trying to capture the historical trend, right? That goes back to around February in 2020. So you see the model is trying to fit a bunch of months of data, right? And it is doing a good job here. And then we forecast ahead 20 days, okay? So this is the United States back in, as of July 4th. This is as of July 12th, yeah? And this is the most recent one we did last week on July 20th. That shows that the national curve is already likely reaching that peak, is bending, okay? And we're due tomorrow to generate the next set of forecasts. So, you know, in summary, I think there's a great opportunity given the amount of data and the detail of data that is being collected in many places, including contact tracing data, as Alun also mentioned, from those contact tracing strategies to mitigate outbreaks that can help us inspire the new generation of models. And again, recording how well our models are working, how well they are failing, we can actually improve things, because it's when the models fail that we can actually take note of that and strive to improve them. Yeah, thank you, Anush.
Thank you very much, Professor Chowell. This is a fantastic presentation on how you guys are tracking the current pandemic trends, especially the importance that you have pointed out is the role of heterogeneity at the local scale, and also the integration. The reason initial model might not have probably have able to capture it well is because of the maybe not able to capture the proper variability, such as like super spreading events. Also, it's like it was great to see this simple but model that could captures the current trend quite well. And the forecasting that you all are doing is like 20 days at the most. That is what I'm getting out of it, rather than 3 months or 4 months or something like that. So these are some of the important aspects. And thank you once again, Professor Gerardo Chowell.
Thank you. Yeah.
So I'll further continue. Go ahead, Gerardo. You were saying.
I was going to say maybe, yeah, maybe questions for Mac, Alun. That would be great, because yeah.
Yes. So we are now heading to the panel discussion, and what I would do is I would request each of the panelists a separate questions, followed by response from the other two panelists. With that, let me start with my first question to Professor Mac Hyman. And my question is based on considering many models that were developed in the 1918 influenza pandemic. Are there any of these models that are being repurposed for COVID-19, or models or we are generating the models from the ground zero for COVID-19? So there has a lot of been literature on the other pandemics, especially the 1918 pandemic, influenza pandemic.
The answer is yes and no. So the large scale models, like the model at University of Pittsburgh, University of Virginia, Los Alamos, taking 20, 30 programming years to develop. And they've been made flexible enough so they can be applied again and again to, especially for influenza, epidemics that spread like influenza. Now this epidemic, and then everyone and their brother and sister is making their own small compartmental model to answer questions such as what's the importance of face mask, hospital spread. But some of the major things about this model, about this epidemic that are different than the previous influenza epidemics is first, there's a massive use of face masks. And we've never seen that, at least in the Western countries. In the Asian countries, yes, but not in the Western countries. And so this has to be explicitly added. Aerosol transmission in the past has been rather a minor component to the spread of influenza. That may be one of the major transmission routes for this one. There are also behavior change, wearing a mask, reducing your contacts, has been very dependent upon age. So young children don't go to school. The 20-somethings tend to change their behavior far less than the elderly people, who are, many of them taking the lockdown seriously because of disease progression and mortality. Morbidity and mortality is much, much greater in the older population than the younger population. So if you're going to use the model to predict hospital bed needs, then the model has to include age. So we're hearing now in the US how the fewer people are dying, whereas more people are being infected. So we must be doing a much better job at treating the illness. Well, in the early epidemic, the people that were infected and dying were mostly old people. And there can be as high as a 14% hospitalization rate for the older population. And maybe 20% don't come out of the hospital. Whereas for the younger population, it's a fraction of that. Only 1 or 2% become hospitalized. And the current epidemic, we're seeing it more in the younger people. So the model, if we're going to repurpose them, we have to have age-dependent behavior, have to have behavior change, face mask, aerosol transmission, and possibly fomites. That is still an unknown role. Fomites are when the virus gets put on a surface, it's known that on plastic, the virus can live for up to a day. It's not known what role, these are fomites, so the live virus on the surface. It's not known how well these fomites can infect other people. In the early epidemic, that was one of our biggest concerns, that people could say go up the stairs and touch a hand railing, and then someone else could be infected by it hours later. It appears not to be playing as big of a role as we thought, but if it does play a role, that will have to be added to the models. So the answer, there's not a simple answer to your question, I guess.
You think, Mac, that you know, the fact that this virus is likely very well spreading in through the airborne aerosol mode, is that exacerbating the super spreading potential?
Absolutely. Right? I mean, the choir, where one choir member infected the entire choir, is a perfect example. And so the models for flu, there were super spreaders, but they didn't play as big of a role as they are in this epidemic. Many of the previous epidemics, we could assume homogeneity in the population. For this epidemic, we can't. It spreads very different. The role of asymptomatic people is huge in this epidemic. And so, like Alan was saying, if we put in we have to have contact tracing to be able. The very long lifetime of an infected person. And the flu, you typically got sick when the day or two you stayed at home for the rest of the week. Here we have people possibly spreading the virus for weeks on end. Now our influenza codes can be adopted to include this, but these are major changes. It's not a major change in the underlying mathematical model, but it's a major change in the parameters that we're using those models.
Right. Yeah. Yeah, I'm thinking about the serial.
Gerardo, your model is oblivious to a lot of this. It's more of a statistical trend model, but we're using an underlying mathematical formulation to pick these up. And so when we don't know all these factors, that's why I tend to have more faith in those models than I do the pure mechanistic models.
Yeah.
Yeah, go ahead.
Right, exactly. So it tends to exploit the structure in the data. It's not only statistical, but it's also mathematical because it has the mechanism, the generation of the sub-epidemics, right? And I think that's the key here. I was gonna say something about the serial interval or generation interval for COVID-19 versus flu, because also Alun has done a lot of work about this area and how the variation in these quantities shape the dynamics of the diseases. You know, there are some estimates out there about the generation interval and the serial interval mostly for COVID-19 that put this number around 5 days, and there's some substantial uncertainty. But, you know, up to what extent do we, you know, rely, we give confidence to these estimates, given that, you know, if this virus is really spreading through the airborne route, how well are we able to contact trace and link cases, right? When you have many people in these settings, and there might be a lot of confounding when we try to reconstruct these numbers. So is there, yeah, any thoughts on that? Alun, have you thought about, can you say something about that?
Well, particularly as has just been said, when we weren't sure about the mechanisms by which transmission was happening. So transmission, you know, a given transmission event might have been ascribed to one pathway, in which case a certain way of doing it would have been the plausible way. Whereas if it's aerosol, it could be quite different. And as you alluded to, a lot of the estimates that you do from some of these mechanistic models are very sensitive to those serial interval distributions. And so uncertainties there, you know, even small uncertainties there can propagate into large uncertainties of quantities like reproduction numbers that you estimate from data.
Mm-hmm. Indeed.
Well, one thing I think this epidemic is pushing us to, and we've been getting by with scalar parameters, for instance, from time from infection to recovery. Because the distributions have been fairly short, and we can approximate, say, an exponential distribution with a constant recovery time. That may not, that we may find ourselves that we have to accept that there is a broad distribution for this epidemic, both in the behavior of people as well as the disease progression. And so our little ODE models become differential equations and integral equation models. Or we bite the bullet and go to agent-based models, which are can much easier handle individual behaviors than our continuum models. So I think this is one epidemic where the agent-based models really have significant advantages, because we can, whereas if we do a continuum model and we include age, face mask usage, disease progression, number of contacts per day, each one of these acts as a spatial dimension. And it's very easy to come up with 5 or 6 or different variables that are important. That would be like solving a 6-dimensional PDE, partial differential equation. 3-dimensional PDEs are hard enough. Okay. Whereas for agent-based models, if you have 1 million people, you have 6 traits, it only goes to 6 million unknowns or 6 million variables. So agent-based models are a way to at least help fight this curse of dimensionality when we find more and more aspects of a person's behavior are important in the transmission.
Thank you very much, Professor McIman. And I know this, the model that you were referring from University of Virginia was, you were the one of the initiator on EpiSim, if I'm not wrong, that is what you were referring to.
It had its roots in Los Alamos.
Okay.
Pretty much at the time that MIDA started, so about 20 years ago. So this is, and then it went to Virginia Tech with Stephen Eubank and Madoff, and now it's at University of Virginia. So this is an example of a model. This particular model probably has about 60 person years of effort into developing it. And it's not, and it's only because we've had these past 20 years that we're able to apply it quickly to this epidemic.
Sure.
Your question about using old models, well, this model was able to be retooled in a matter of weeks. Whereas if the infrastructure hadn't been there, we would still be at the very early stages.
Sure, sure. Thank you very much, Professor Hyman. I will now ask my second question to Professor Lloyd. and we can continue this discussion. I know each question will have multiple responses and multiple directions too, but just for the sake of the time, I would now continue with my second question with Professor Lloyd, directing this question to Professor Lloyd. What have been the roles and practical impact of mathematical models in addressing COVID-related problems for different populations and regions, such as models being used to direct lockdown or reopens? So what has been the practical role, where we are seeing the practicality there? Can these models be used for, now we are debating on how do we open the schools and colleges. Can we use these things practically to say, okay, these schools could be opened, okay, these cannot be. So some of the practical roles, if you can talk about, that would be very helpful.
Yeah, well, actually what's interesting to me is that there's been quite a disconnect between modeling and policy, it seems. Now, I guess in the US, it's been almost pathological. But in the UK, it was also quite interesting because, you know, there was a large modeling infrastructure in place there. So there were modeling teams that were looking at this thing straight away and, you know, advising the government on a week by week basis. And it was interesting to me, at least, how the decision to enter a sort of a lockdown at the UK level was slower than many people might have expected. And I guess I guess I was there for spring break. I was in the UK for spring break, so that was early March. And I think we had the first nationwide press conference, government press conference on coronavirus at that point. And I guess the lockdown started in mid to late March. And I think the change in thinking there was triggered by the realization of the high hospital rate that was going on in Italy. So they realized that the public health system in the UK, you know, the beloved National Health Service, would be overwhelmed. But now, you know, the big debate in the UK is over reopening schools, as it is in the US. Yeah. And so, you know, there are lots of modeling efforts out there, again, as Mac talked about, with age structure, trying to figure out the roles of people of different ages in transmission of COVID. As you say, you know, situation is different in different places. And so, you know, the models are often coming up with different predictions in different places, given the situation that's going on. Of course, the other thing that we can't avoid is that this doesn't just sit in a modeling and a scientific context. There's a big political context going on. So particularly in the US, you know, I guess we've seen the different states, you know, different, you know, like Florida and Texas, I guess, at the moment, and maybe even California, poster children. So it's an interesting thing to me how this sort of modeling and science sits within a broader societal context that we can't really ignore.
Mm-hmm. Okay. So I think what you are saying is these are context is very critical, and the implications cannot be generalized to the whole world. If we are building a model that could be at a local region, could be applicable in some sense, but if we want to do at a national level, there needs to be more heterogeneity, such as age structure or some other aspects which are critical for that particular, including the policy changes. That is what you are. Yeah. Mac, do you want to add something, or Gerardo, you want to add something to what Ellen was referring to? So the question that we were kind of debating was on whether there has been a practical implications that we have been using currently from these models for the COVID.
I share Alan's disappointment that that many of the practical suggestions that come from the models are not being implemented. What seems to have the most impact is when the models, even simplistic models, if they have visualizations of what might have been if we'd started the lockdown 2 weeks earlier or 2 weeks later, you know, these are visualizations that someone with no understanding of modeling can understand. And they're completely independent of the quality of the underlying models that produce them. And so I guess as far as the impact, so far I've seen very little impact other than the big news stories that, you know, if Texas had kept the lockdown on for 3 more weeks, this is the projection of what would have happened. Mm-hmm. Gerardo, what about you? I mean, are you equally disappointed in some sense?
Well, perhaps the piece of good news is that there is now some studies that are showing that these lockdowns, the social distancing interventions and shelter in place orders have had a significant effect on reducing transmission or reducing the reduction number for some period of time. At least, you know, that amount of effort had an impact that is significant. And I think we can use that information if we want to move forward and implement another lockdown, hopefully not, later on. We have some evidence that they have had a significant effect on transmission. So there's this study I was involved, led by a fellow at Cambridge University, where we find that, you know, there's a significant impact of the lockdowns when you look at the data from 149 countries. And there's a more recent study that was published 2 days ago from, I don't know exactly the group, but it was published in JAMA Open Network. And they found that in the United States also there's a significant impact of the social distancing interventions, even when you control for weather, the weather and other factors. So that's good, but obviously those interventions had a profound economic impact in many places. And so that's the drawback, right? So now, yeah.
Keep going, Gerardo.
I was gonna say about the resurgence, right? How well the models predicted that the virus was going to resurge and the timing of the resurgence when we started to ease the restrictions. That's another question, right, that we can assess with the models. Which models tended to do a better job at predicting this resurgence? Because as far as from what I have seen, most models tend to resurge very quickly. As you start to ease the restrictions, you know, the exponential growth goes back.
There's not a time delay that we know exists.
Right. And for instance, Georgia, right? In Georgia, we started to open the economy relatively very early in the United States, but the resurgence didn't materialize until early July, let me see. Yeah, early July, I think. Although we always have had a high level of incidence, relatively stable, but the actual growth back up didn't occur until probably a month.
Something the modelers could have done better to explain that, yeah, when you change the lockdown, you'll get exponential growth, but the beginning of an exponential looks very, very flat. Mm-hmm. And I think that's what happened in Georgia. Those first few weeks afterwards, you were at the early exponential. Mm-hmm. And I think what happened in Georgia, forest fire is a good analogy for this, is that, you mentioned Georgia. California is another example where it looked like early on California really had the thing under control. And then when they started to release the background, it exploded. I mean, the lockdown, it exploded. And you might think of the forest fire analogy. In the early stages, you had a major fire or two, San Francisco, Los Angeles, and we drove it down. Well, while it was being driven down, you get embers that were spread out over the entire state. So then when you lifted the lockdown, you didn't just have 2 fires you were continuing with, you had hundreds of small fires all exploding at the same time. But they all started on a very, one person in town infecting 2, infecting 4. So it takes a while for these exponentials to take off. But when they did, it looks like it was almost a discontinuous explosion.
Yeah, I'm thinking this is like a percolation process, right? You have all these fires that you say, Mac, and then suddenly they percolate and they synergize and get something
I'm not
bigger.
sure it's percolation because there's not really communication between the fires, I think, in this case.
Well, people are moving, right?
People
So
are moving, right? So I think that's what seeded the embers throughout the whole state. Whereas in the early stages when they had the lockdown, it was really localized to just a few places.
right, right.
And similar things may have happened in Georgia. I'm not as familiar with Georgia.
And
Well,
another point to make about the end of a lockdown is just because the governor announces the lockdown ends doesn't mean that everyone goes back to their pre-lockdown behavior initially. So, you know, people might still have, you know, concerns and so on. And so they're tentative at first, and then maybe after a week or two, they don't see so many cases. And so they're a bit more adventurous in their behavior.
Mm-hmm.
And so, you know, these changes aren't as sharp as maybe one might like to imagine.
Mm-hmm. Indeed, I agree with that. That's right. The relaxation is also another dynamical process that is happening.
Exactly.
Right? Yeah. Relax.
So interesting views to hear. Basically what I am getting as a summary of everything is this is the question is not whether there has been a practical applications or not. The question there's a spectrum of implication. It could be small to at a local level, or it could have rather than a big, I mean, the implications or the practical applications have been immense, but at a small level in various examples. And one of the things that are directly relating to it is a policies that is also dynamically infecting the epidemiological processes underlying it, basically. So, well, I kind of, we are actually running a little late. I would quickly have our third question from Gerardo, and then maybe we can have one or two questions from audience as well. So the third questions to Professor Chowell is actually on the same lines. The California seemed to have everything right early on. Why are the cases of COVID surging now? If any math models can play their roles in reducing disease burden there. I mean, California has been doing like a lockdown very early on, but now its cases are surging back again. So if everything went on fine from a policy perspective, what has done wrong? I mean, is the models can help in identifying what are the mechanisms that are driving this current surge?
Yes, I think, you know, Mark and Alon already discussed part of this. And, you know, it goes back to the contact rate, how the contact rate has been increasing, right, since the economy started to be reopened and the restrictions relaxed. And so we have a substantial fraction of young individuals that are mixing with each other. And, you know, essential services and many jobs have been restarted. So many opportunities for transmission have been restarted. And that's certainly, I think, the resurgence is driving those. But it's good news that I haven't seen a lot of news about nursing homes being hit now. I think, as Alun also alluded to, there has been a lot of protection now in these populations, and, you know, not only behaviors but also new protocols that have been put in place in these settings, not only in hospitals but in also nursing homes and those type of places housing highly vulnerable populations. Yeah.
Well, this is something that what we saw it in Washington State initially. That was driven by the nursing home outbreak contact process. Whereas what you were suggesting is probably in the age structure, contact rates might be the reason for this recent surge. Because people were kind of relaxed that it is an old age disease rather than a young disease, and they were kind of not strictly following the young group was not strictly following the restrictions, and the contact rates were changing because of that. So
yeah, in simple terms. Yes.
Ellen and Mac, can you want to add something to what Gerardo was mentioning?
Don't have much to add.
I don't know. I think yeah. One of the chat questions was, could it happen in New York? I think it's less likely to happen in New York because of the proactive response that the governor has been given for the state, as well as the mayor for the city. And so they are really watching the trends very carefully and are willing to scale back things quickly. Also, the media has done an exceptionally good job, I think, for the New York area, explaining the importance of wearing a mask and social distancing and the impact of not doing it. More so than, say, in some of the central US states. So I think it's less likely that we'll have such a surge back in New York. I think we'll have once the trends start going off again, I think they're much more willing to dial them back there than elsewhere in the country.
Sure.
Yeah. Yeah, I think this is an unprecedented time. You know, this is the first pandemic where we really, hopefully, will see the outcome of using face masks and all the protocols that are being put in place in school settings and workplace settings to mitigate the spread of this new virus, right? So I think it's quite unprecedented.
One thing I would like to say, as far as monitoring what's happening, one of the most difficult things about modeling this disease is the way that the data often has been presented to us that's available. For example, they often mix antigen tests, which means you're actively infected with the virus, with antibody tests, which means you may have been infected 3 months ago. So we just get case numbers for the number of infections detected, not whether it is an active case or it is a past case. And so this is data that existed when it was taken, but is lost and stripped of that information as it moves through the pipeline. And so as we're monitoring and modeling these states as they lessen the lockdown, unlock the locks, we really need to be looking at the antigen test, the active virus, not at the antibody test. And so for the models to play a continuing role in the future, we really have to separate the data so that we're modeling the data that we think we are.
Mm-hmm, mm-hmm.
The other big unknown, as far as when they start unlocking the lockdown, is that test data is only for the people that actually actively go in and ask to be tested. We don't know whether there are 3 times or 10 times as many people infected as the cases that are reported. And this is going to take random sampling of the population, which typically has not been going on or been going on very, very little. I think that will change tremendously when the schools open, because the schools that do open, many of them are starting to do random testing, whether or not you exhibit symptoms or not. Mm-hmm. And so we'll start getting an estimate for what is the true hidden epidemic. We're only seeing the tip of the iceberg, those that get tested. We don't know just how deep below the surface it goes. And knowing that will be critical to monitoring these states as they reopen.
Mm-hmm.
Okay. Thank you, Mac and Ellen and Gerardo for this lovely panel discussion as well as their input. But I would like to ask very quick one question from the audience. It is on, I mean, this question comes again and again, and I see it in different talks, and I don't know how to answer it. Maybe you all can help in this. Which model or modeling approaches is most suitable and reasonable to estimate, and under what conditions for the COVID? So there is a recipe, basically, that we can use some black box, or that box we can take out some things and use it in certain scenarios. There is any things like that?
Yeah, it depends on the question. That's what I would say. What do you think on?
You start with the question. What is the question you're trying to answer?
Okay.
Al?
Ellen, you want to say something on that?
No, that was exactly my point. You said to estimate, and I was thinking, well, to estimate what?
Right.
Okay. So
Let's finish this, Anush, because you know the often quoted thing is a model should be as simple as possible, but no simpler. And so you start with the question, and then you ask, what are the relevant factors that I need to include to help me answer this question? Okay. And then you slowly pare down your model. And so once you have a model, then you can do sensitivity analysis and uncertainty quantification on the reduced model. But also equally important, you need to test some of those factors that you threw out. You need to throw back in and just see how important they are before you finalize your results. Make sure you didn't throw out a term or parameter that was important that you assumed that was not. But you start with the question and then you start building the model.
Mm-hmm. And what data you have at hand, right? Also,
That's right.
Much data.
well, this is fantastic. I think the points that we are writing down some of these points, and we will try to put the summary of these things online as well. But I think if you all can say some closing remarks on that. So for example, Mac was mentioning about what is your goal, what is your research question, that, and Gerardo was mentioning about the data. Ellen, you want to say something on the on this particular question?
Yeah, well, so I just saw there was a question about antibody tests. And of course, I mean, one reason why the antibody test is of interest is, okay, so it doesn't tell us about active current infection, but it maybe tells us something about the level of immunity in the population. So that's one of the big questions at the moment, is what does immunity to COVID-19 look like? And of course, you know, most of the strategies that people have talked about have been with the aim of, you know, at some point we're going to reach herd immunity. And that, of course, the initial assumption there is that people have some sort of relatively long-lived immunity. You know, and then we're hearing these stories about, you know, antibody responses falling off over time. So then there's question whether the immunity is waning. Of course, antibodies aren't the only form of immune response. So we have to be a little bit careful in making that leap. But, you know, I think that to me is one of the worrying questions right now, is that if immunity to this is short-lived, we're in a different situation than maybe we thought we were a few months ago, and one that is a lot less rosy, to be honest. Well, even less rosy. Of course, it could be that the vaccines that are under development would give a longer lasting immunity than natural infection. We don't know. But I think that, to me, that question of immunity is a big one at the moment in terms of what the long-term future of this infection is going to be.
Go ahead, Mac.
Put that in perspective, one of the quotes from Tony Fauci, was that he's never seen a disease, infection so infectious since measles. And herd immunity for measles takes, it's somewhere between 90–94% of the population needs to be immune to measles at any given time. And so if we need 90% of the population immune to this coronavirus at any particular time, and there's a waning of the vaccine, then we're looking for a very long road ahead.
Fantastic.
Don't throw away your face mask. We'll need it. Here to stay.
Oh, I think many of the things we're doing now are going to stay. On the upside, hopefully the flu season won't be so bad this year because of all these things we're doing. And as far as my final statement, Anush, I think Niels Bohr said it better than anyone. It's very hard to predict, especially the future. And that these models, they really aren't crystal balls, and they can be confusing to interpret. I like to say epidemic forecasting is messier than weather forecasting. Right. Because the weather has you know, the air acts the same from one day to the next. People don't. And so we've got our models to really forecast. We have to convey the uncertainty. And we also have to deal with the tail ends of very broad distributions of behavior and response. And on the other hand, the only thing worse than not having any, well, at least we have some models. And one of the worst things, that's double-edged swords, because it's far worse to have a model that's wrong that you believe in than to not have a model at all. And so we have to be very careful not to give our models unjustified confidence and end up making bad decisions. So that's really the point I want to pass on to the listeners.
Especially when we were trying to, sometimes I've seen that we are interested in modeling like 3 months, 4 months in advance of when we don't really have an understanding whether there is a permanent immunity or not, for example.
Anyone that tells you they can predict this model 2 months in advance is either a fool or they're lying.
Well, this is very helpful actually, and I think with the time running out of our hands, I would like to really thank all the panelists who has helped us to understand at least a basic understanding of how we think and how these models have been helping or kind of making our understanding better for the current COVID-19 pandemic. Especially this entire world has to change their normal life. I mean, we really don't know how we will cope up with this change in normal life, and which will also affect our future. But having said that, I hope that this session has provided some understandings to the to the audience in pursuing the modeling work in particularly. I mean, we are lucky to have all three of you as a panelist in today's. This is, you know, and also because of you all, I have seen some of your interviews also. I'm talking to 3 panelists here. And how beautifully you all have, in various podium and various social media network, complex idea you have explained. And this is the great achievement for mathematical models. I think that now common people are talking about these technical terms as if it is a common knowledge. So thank you all for giving our time to us and talking to us on different aspects of modeling. I want to bring this session to end, and with some information about our, this is just to give you, this is not the only one session. We would continue as a series, and we'll bring experts, and we will have the same experts also on our website, and the informations and the interaction with the current experts as well for different topic sessions in future. Every week we are actually doing three weeks we have already planned. The next one we will have it on linking data to models, also related to COVID. And we will hope that most of you would be able to join for our sessions, webinar series. In fact, what we have done is we might be able to provide some certifications to some of the participants if they are interested in participating in these webinar series. Having said, the organizing committee has been kind enough to say that if participants are participating in 3 or more webinar series, then we would be able to provide a free membership for the 2020 BEER conference, which will be virtual conference, but you would be having a free membership for it, as well as reduced article processing charges for letters in biomathematics journals. So this is a good things for us to motivated enough to be part of this webinar series and continue to be giving the feedback. We have provided, let me share very quickly my screen. We have provided a survey link, and we will send it to all the participants to have the feedback so that we can also share some of these, your inputs to our panelists, as well as we can draft some of the responses from them on our website. So with that, I thank everyone for joining us today and making this session an exciting one. I hope it has been useful to many, and just wanted to ask any of the panelists want to add few things to it. Otherwise, we would end the session.
Well, thank you all for organizing it.
Yeah, thank you.
Thank you. Yeah.
Thank you. It's our pleasure.
Okay.
So please do not forget to fill out the survey online. We will send the survey. It will be really helpful for us to keep going this way and boosting our energy. I have a wonderful weekend to all of you. So thank you.
Thank you.
Thanks.